let's talk about money, right? Everybody has a certain amount of money, and you choose how you're going to spend it. And you can choose to spend it, just using the information that you can think of, or you can hire a financial advisor who can maybe help make you smarter about that. However, you're still making a decision that I'm going to choose to use and spend something now versus saving it for later. And so I think with the human body, what we're looking at is how do we slow the rate of deterioration? And that, it's tires on a car. That's my analogy for my patients about discs. And that, you blow your right front tire and you get it replaced. Okay, that doesn't fix your left front tire. And maybe you can put all those miles on your car next month, or you can put them over the next 10 years. And so that's where I think the human interface comes in to utilize the adjunctive data that's been presented. And so after that really mind-bending talk, thanks, Izzy, I'm going to go much more nuts and bolts, okay? So my disclosures, and my other disclosure is I think I operated on all of these patients. And so from Lukey Galveston to more modern techniques, spinal pelvic fixation has evolved. What hasn't evolved is that to get something to work, you've got to have a device that grabs a hold of the bone. And if the bone is styrofoam, that's a problem. If the bone is oak, it doesn't care whether it's old oak or young oak, it cares whether it's oak or styrofoam. And so that we've learned how to use the data that we have from CT scans to do opportunistic bone mineral density. And so where you put your screws matters in terms of what the bone quality is. And so optimized S1 screw fixation starts with medial trajectories to get into the good bone stock. And this biomechanical data goes back a long, long time, back to when Izzy and I were rookies, and I think Pat too, and that we learned that medially convergent screws work better than laterally divergent screws. And then we learned that if you go to the sacral promontory, you double the insertional torque, and it doesn't cost you any more other than just getting it in the right place. If you take away one biomechanical study today, this is an oldie but goodie, and it looks at when you're fixing to the pelvis, the loads are profound, and that when you have something that extends anterior to the pivot point, it performs biomechanically much, much better. So then how do you get there? Well, we've known about the teardrop view and the iliac trajectories for a very long time, and that there are a variety of paths that we can use. And then the question is, how far do we have to go to optimize? And so one of my partners looked at that, and the answer seems to probably be about 80 millimeters. At 80 millimeters, you hit a second narrow point in the ilium, and the insertional torque goes up substantially. The group here in Seattle has done some really elegant work looking at available bone channels and how to optimize those, and that you can get multiple points of pelvic fixation in a reliable fashion. What AI does not obviate is human anatomy. It may help us avoid the problems, but I think we as surgeons absolutely need to know what the perils and pitfalls of what we do are. What AI does, or what augmented reality or navigation or robots do, is help us stay within the bone channels. We've learned some things that different trajectories work a little better than others. I'm a fan of the S2AI trajectory rather than an iliac trajectory, and there is emerging fairly compelling systematic review data suggesting that it has a lower complication rate. Anytime we do anything, we need to think about how do they fail. And failure mode analysis is really, really critical. So going back to Izzy's pilot analogy, this is the black box retrieval after catastrophic failures, and then going back and trying to reverse engineer and say, why do things happen the way that they do? Well, there's certain high critical stress points from finite element modeling. So for conventional iliac screws, it's at the offset connector in the tulip head junction. S2AI, it's where it crosses the joint. Modified iliac, again, is right below the tulip. So design our implants so that they minimize these stress points and optimize our overall performance of our implants. So do we have a problem? You know, in my world of adult deformity, we focus so much on PJK, PJF that we've sort of ignored the foundation. Well, it turns out our foundation fixation failure rates aren't so great, that we have a third or so of our patients have a failure mode, and of those, 5% are acute failure modes. That's not a fusion failure, that's an instrumentation and fixation failure. And so from our group in Minnesota, we looked at, this is Chris Shaffrey's group at UVA, and they reported a 34% failure rate in pelvic fixation. Not all needed revisions, but a high failure rate. The best group of surgeons collecting data to date is probably the International Spine Study Group. Their high-quality data shows up to a 25% failure rate, resulting in a high rate of reoperations for failure of fixation to the pelvis. So we looked at acute failure in our group at the University of Minnesota, and we found a 5% acute failure rate in these big sagittal plane deformity correction cases. And the failures were catastrophic kind of things of pulling loose, fracturing, falling apart, requiring revision. So if we try to do our black box analysis about why does that happen, this group out of Seoul, Korea did a real nice study analyzing by location of their failure type. And again, finite element modeling, trying to tell us why do things behave the way they do. So when something doesn't work, we move on to say, how can we do this better? And so the answer of stack screws, multiple rods, and perhaps simultaneous SI fusion can perhaps improve this. And I love the comments about what is the effect on the adjacent joints. And so in fusion to the sacrum, up to 24% of patients develop new onset SI joint pain. Biomechanically, we completely understand this, that an L4 to S1 fusion increases the motion on the SI joint by 168%, exceeding Izzy's threshold by a pretty fair bit. So can we optimize that? Yes, if we simultaneously fix the SI joint at the same time, we protect the stress on the S1 screws, overall improve performance in our construct for failure modes. And so, yes, we can show biomechanically that we're markedly reducing the loads on our failure locations. So then the next question is, can we technically do that? And the answer is yes, we can. And that what we've learned is that with adjunctive technology, we can reliably place multiple devices in these corridors that maybe before we had some more challenges with. So now I love to show my spine eye candy of how have we walked down this pathway. And so this is the kind of patient population that I see. Actually, this is atypical because they haven't had multiple previous fusions. You know, we can realign the spine, we can put it in a better place, and we can create a firm foundation, and that we can do multiple screws. This case always brings back wonderful memories. She had ossification of the ligamentum flavum. Every time we did a Smith-Peterson osteotomy, we got a dural tear after about 5 levels. I said, enough of that. And then, you know, you do surgery a number of years ago, and it looks really good, and then the patient comes back 2.5 years later with a broken rod, and you're kind of like, okay, why did that happen? We did it all right. And that what I learned is that S2AI screws don't fail in the ilium, they loosen in the sacrum. Why is that? It's about the bone. The bone is softer in the sacrum. So we salvaged her, and she's gone on to do reasonably well. How many can you put at the bottom? You can put a fair number, and the kickstand strategy has become popular. So stacked screws with a kickstand in addition, and we'll try to demonstrate that in the lab today. Where I've gone today is to a quad screw, quad rod construct. Why? Well, if you have a known load going across your bridge, and 2x4s will handle 80% of the load, but 4x4s will handle 98% of the load, what bridge do you want to cross? I hate doing revisions, especially on my own patients, and that the opportunity to minimize that is really what I'm going for. And so we can get these kinds of excellent correction, and I like the head-to-toe imaging to really understand that as humans, we don't function from T2 to the pelvis, we function from the occiput to the feet. And so these kinds of kickstand strategies, and even more than 4 rods sometimes when you're trying to get your deformity correction. And I don't think the rods are going to break here. I think we still need to get a biologic solution. So nothing decreases enthusiasm like follow-up. So this dentist I had operated on 9 years ago broke his rods, and then we revised him. So let's talk about, so biomechanically in modeling, 4 screws, 4 rods is superior in terms of robustness of fixation. How do we do this? So the first thing is understanding start points. So we want to be caudal in the teardrop so that we have room to place a second implant above. So here's our trajectory, and that what we want to look at is that in the past we wanted to have be at the bottom, and now what we want to do is we want to be able to stack the implants. Typically, this entry point will be caudal to the dorsal foramen of S1 and just above the S2 foramen. I try to be just above the sciatic notch. That's the best bone. So here's a representative case example. The flexibility analysis. We do get the CT scans, and the scouts from the CT are very helpful. I do utilize the preoperative planning. I think this makes it better. And I'm a trust but verify guy, so I put the implants in and then I verify with 2D imaging. And you can see that you've got to get just the right teardrop view to really tell you that in fact you're in, because if I look here, I look like I'm out laterally, but in fact we're not. And then the navigation screens demonstrating what the implants look like as we place them. And then I do a check spin so that I leave the operating room knowing that my implants are exactly where I want them to be. And in this case, we're able to place stacked S2AI screws and a kickstand, getting this kind of correction and alignment for the patient. And here we see the preoperative to postoperative change, and she's beyond happy. Can we reliably do this? We've looked at our series of our initial 1-year experience doing this. So 74 patients. We had 235 implants placed. We had a malposition rate of about 6%, and most of those were in the cephalad implant. Here are all of our intraoperative malpositions. All were able to be repositioned intraoperatively. And then this is what I'm going to for my current strategy at this point. And we'll stop here. Thank you very much.
Do I get to start again as usual? I guess
You are the chair.
That's a theme, I guess. I started this meeting 8 years ago. I guess I'm still doing it. David, can you comment on the use of navigation versus standard imaging, which fluoro, plain X-ray, and things like that? Because I know you're a big proponent of it, and I listened to all this, and it's like, and you have also really, I think, set the standard for some of the pelvic fixation of what we do in the country, you know, and looking at failures. I mean, but how do you integrate navigation with your other modes of imaging intraoperatively?
Yeah, so I utilized intraoperative cone beam CT, and we bring the unit in and leave it in the field, and then do fluoro shots with it. So that's a little bit resource intensive. And so at our place, we've got 2 units, and we really only run 2 big spine rooms a day. If somebody's doing an ACDF or something like that, that can go in a 3rd room. And so that we have dedicated support to make that work. There are other places where you got to take it between rooms, and that's a little more challenging. And so what I would tell you is my return to OR rate for screw malposition since 2006 has been 0. My intraoperative change rate is between 1% and 3%. So I had not had a pelvic fixation problem until 2 weeks ago, and I had a screw that was one of the cephalad screws that had a medial perforation, and I had to shorten it up. But I was able to do that intraoperatively, and instead of putting in a 90 millimeter screw, I put in a 70. And so that I think that for me, you know, you joke about what you do with navigation. The joke at my place is that I brush my teeth with navigation. And so, so I'm a big fan of it, and that we use it reliably. But I think it's critical that you have to understand what it does and what it doesn't do, and that the concept that limits us today is we put a reference frame somewhere and we operate remote from that. And if there is intersegmental disruption, then your navigation is no longer accurate. And so the next step in this technology is going to be that segmental analysis as we move. And the good news for us is bone is a rigid 3D body. And so if we know its shape, and we can identify a surface of it, then we should be able to do that relationship analysis and change.
Dave, so quad screws, quad rods is your preferred way to go now. Are you doing quad rods because L5S1 isn't fusing, or are you doing quad screws because the screw caps keep popping off, or why are you doing quad rods, quad screws? What's the main issue? Or are you doing it to encompass everything so that nothing fails?
Right. So I think you elegantly answered your own question, Terry. And that what I would tell you is that analyzing the failure modes, each failure mode has its own set of problems, right?
Right.
And so that both being involved in a design team to improve the implants to avoid those failure modes, and then to over-engineer the construct at the base so that there is not a foundational failure. And inevitably, a certain number of patients are going to have degeneration above as part of the aging process. We haven't solved the senescence problem yet. And that when they do, I'm not going to have to go back and redo the foundational work. The foundation's going to be solid, and anything that needs to be added onto that will have a firm foundation.
Sounds like AI might be something useful here as you plug in all, because what you're saying is there's a million different data points, and it's just easier to do your construct to get it to fuse. But certainly you would think this more for someone who's really sagittally imbalanced, osteoporotic and things like that. But adult idiopathic 56-year-old normal, not really out of alignment, you could get away with 1 screw, 2 screws, 2 rods, not 4.
Yeah, so that's a really great question of how much is enough.
Yes.
And the answer becomes, what is your tolerance for failure? Okay, so if you've got to go help somebody move a load from point A to point B, and you have a sports car, you're going to be able to carry X amount of load. If you got an SUV or a pickup truck, you're going to be able to carry X plus load. And you get there and you find out you didn't really need the pickup truck. You could have done it in your sports car. But when you get there with your sports car and find out that you really needed your pickup truck, then you've lost an opportunity. So it's how much over-engineering is too much, and that's a good question, and maybe Izzy's technology will get us to the point where we're smarter about that.
So just one cautionary note, and I know, Dave, you see a lot of revisions. I see a lot of revisions. What I fear that we're propagating now is more metal. And we know the answer is not more metal. The answer is biology and biomechanics, using the metal appropriately and ensuring the biological fusion for those that we need to fuse. So I'm seeing individuals right now putting 6 rods in, and I'm wondering why. It just makes no sense. And all that they're doing is creating this big, massive dead space underneath the incision that gets in the way of the fusion, that they can't close the skin. The skin then breaks down. You've got all this artifact when you try to image. So I think we have to really emphasize biology, biomechanics, and using the right amount of metal to address it.
Yeah, so anything done poorly can give a poor result. And things done excellently can still give a poor result, but hopefully less often. And that, Pat's comment earlier about he hates fusion, because fusion is a terrible answer. It's just for some of these problems, it's the best answer that we currently have. And so how to optimize that is a work in progress. And that what I have gone to We don't have a lot of soft tissue problems with this because of the S2AI location. And that if you get your pelvic fixation solid, what's the next point that's going to fail? L5S1. And then what's the next point that's going to fail? Well, it's going to bump up somewhere down there. And how do you transition out that stiffness and get it back? Those are evolving concepts and efforts going forward. But I want robust spinal pelvic fixation so that that's not going to fail. I hope that's a fair, and yeah, I clean out a lot of the disc and put a lot of bone graft material in, and I'm absolutely going after trying to get a biologic solution as well. Thank you.